The following presentation addresses the contemporary issue surrounding the increase in adolescent mental illness and critically examines school interventions as a protective factor to mental wellness. The presentation observes some of the current policies in place and displays a proposed intervention strategy to tackle the issue directly, aiming to improve the mental health of society from a school-based environment. Mental health among adolescents is a current topic of concern. Findings in 2011 indicated that up to 2 out of 10 young people experience a mental disorder, and in the UK alone, 1 in 8 young people were found to have at least one mental disorder in 2017. More importantly, the issue of young people's mental ill health is on the incline. Figure 1 is a graph of statistical data from the NHS showing an increase in mental health and emotional difficulties among young people from 1999 to 2017. Even more recently, in 2020, this figure has increased further to the likelihood of 16% of young people experiencing a mental disorder. That's a staggering 1 in 6 children expected to suffer from mental health issues in the UK. The incline in adolescent mental ill health has not gone unnoticed. The government recognised in their Green Paper that there is a high probability of mental health issues in adolescents following on into adulthood. Mental health issues experienced by adults are particularly problematic for the government and the wider community because it prevents middle-aged people from being able to work and heightens the threat of physical health problems, causing higher costs to the NHS. For example, the Green Paper includes statistics showing that, in 2008, depression and anxiety led to a loss of 11.4 million working days in Britain. The Green Paper is a collaboration of the Department of Health and the Department for Education to propose an education-based approach to target and promote the well-being of adolescent mental health. Alongside the Green Paper, the National Health Service England reported the need for improved psychological services for young people, specifically within schools. In 2015, a whole school approach was formulated by the UK government to promote mental health within school students. The approach advocates that every aspect of the school community should work collaboratively in order to tackle mental health and well-being. The government proposes that this approach should be adopted through the care and support of young people, as well as staff, and should include and promote parental engagement. In England, the government pledged that all secondary schools would receive mental health training by 2020, and funding was provided for each school to have a trained member of staff known as the school's mental health champion. This government recognition of the issue conveys its topical importance within society today. So then, why should schools be utilised for mental health promotion? Government officials and health departments in the UK have taken a stance to directly utilise schools as a strategy for mental health promotion in young people, and evidence supports this strategy. About half of mental health issues are said to begin before the age of 14, which gives reason for this age range to be a target category for intervention strategies. Additionally, young people spend a large amount of their time in school, positioning it at the forefront to address mental health matters. This engagement formation between the health service and schools is also argued to be more impactful in making a lasting change in the battle against mental ill health in adolescents. Overall, schools are pervasive environments in young people's lives and can positively impact on their mental health, mitigating some negative impacts of other social factors. Other than policy, theoretical frameworks also support school being the ideal place for adolescent mental health promotion. Brenner and Morris conceptualised that a child's life has different contexts of influence. Using this model can direct which context has the highest level of influence in the child's life to see where an intervention strategy will be most beneficially placed. As seen in Figure 2, the microsystem which represents the second layer of the model refers to the context where the child has direct and regular experience with, such as the family and school. It can be interpreted from the model that the family have more contact with the child's life, which seemingly argues that the home life is a more impactful intervention area to intersect. However, the interplay between home life and school, considering that teachers and school staff are likely to have direct contact with the family, reinforces the evidence that school is strategically well positioned for the promotion of mental health. So, in theory, schools are well positioned to address the issue of adolescent mental ill health, and this needs to be evaluated in practice. One study into the application of the whole school approach to implementing social and emotional skills development identified some commonalities between specific strategies they applied in their efforts. Whole staff training was featured in all included schools, mostly focusing on teachers' use of strategies such as positive communication and cooperative teaching. Staff meetings were commonly used to monitor the intervention's progress, and parents were often included throughout the process. The overall findings were that the whole school approach to implementing social and emotional skills development was ineffective. However, the collaboration with the community had a positive impact on children's well-being through methods such as applying specialist support for children who were seen at risk of developing problems. This enforces the importance of involving the community in tackling the mental health crisis in adolescence, which coincides with Bronfenbrenner's ecological model conceptualising the interplay between the child's home life, school life and community life, forming the argument that a whole school approach is more effective when more of the child's contextual layers are involved. Findings from this study highlight that school is well positioned to form this link and overall improve well-being in more than one sector of their life. In review, however, this study highlights the need for specific teacher training in multiple areas. This forms the view that the whole school approach is reliant on teacher training, which may prove problematic for schools with limited resources or those that place high demands on teachers' time. The efficiency of teacher training and support has been identified as problematic for schools who have adopted this universal approach. Another issue is that subsequent training has been found to cause teachers to feel directly responsible for promoting the well-being of their students, a feeling which they were uncomfortable with. There are other approaches to school-based interventions. Person-centered counselling is a style of talking therapy which aims to make meaning of the client's lived experience. In evaluation of the model, Cooper found that counselling interventions applied within secondary schools in the UK facilitated low stigmatisation, which helps increase student participation of the service. This is useful since participation has been noted to be a major issue with other intervention strategies. The study also found that young people who participated in the school-based counselling perceived the care to be valuable, helpful and meet their needs. The counselling intervention style was noted to be a highly accessible and immediate level of care, which attributes to the government goal of making mental health care more available and reducing the issue of waiting time within the NHS. However, the research found that there wasn't enough outcome-focused feedback within the counselling method, which meant that it was difficult to demonstrate the service's effectiveness. The service was additionally reliant on student participation, which correlated with other methods where intervention outcomes have been found to depend on the number of sessions students receive. Another examination of the results revealed that having external care providers, such as counsellors within schools, brought about a challenge of correlating their practices with the school's existing protocol, raising the concern that, even though in-school counselling integrates the health and education sector in line with government policy, the integration of sectors needs to be a seamless two-way collaboration to be effective. The use of booklets is a micro-scale attempt to achieve mental health awareness and self-help strategies. The method is cost-effective and does not rely on in-school practitioners, eliminating some of the already mentioned issues with school-based interventions. However, one study noted that only a small percentage of students reported seeing the booklets, and they had no overall effect on mental health, quality of life, or help seeking. This leads to the conclusion that a more pervasive intervention is required to make a significant improvement on the mental health of secondary students, such as on-site practitioners conducting interventions of a high methodological quality as opposed to didactic information teaching methods. Another model to evaluate is the cognitive behavioural therapy intervention, which is an outcome-focused method of heightening clients' self-awareness of the interplay between their thought, feelings and behaviours. The model has increased in use by many mental health services in the past 30 years, and it relies on formulating a personalised plan of therapy between the therapist and the client to address their current problems. When CBT was tested in Malaysia, the programme was found to significantly decrease depressive symptoms and reduce negative thoughts. The programme layout and design offer group activities, making it more attractive to participants and meaning that students were willing to fully participate in the intervention. There were no student withdrawals from the practice, which was a big issue for other interventions previously looked at. For example, Salida Tal's study of the Mind Power programme in Norway, only 4.9% of the students were participating at the end of the programme. The author does suggest, however, that the participant retention rate may have been due to Malaysian culture, where students tend to be compliant to tasks within the school setting. Where the intervention was trialled in the UK, some differing results arose. Firstly, using staff to identify clients who needed the intervention revealed difficulties surrounding scaling a person's mental health. This was because staff members held subjective opinions for categorising and defining students' anxiety level, since they lacked awareness of the signs and symptoms of such issues. Also, the students scored their anxiety much higher than the teachers rated it, which highlights that teachers' mental health symptoms awareness was underdeveloped for the intervention to be fully effective. Secondly, the inclusion of staff in the therapeutic process was observed to have a negative impact on student engagement, where the teacher would problem solve on behalf of the students, undermining the core principles of CBT, and the author suggested that staff training of the fundamental ideologies of CBT is needed to overcome this barrier. Alongside this, the study found that the students' self-reported symptoms of anxiety were higher post-intervention, even though the therapy had been described as helpful and positive by participants. In evaluation, this leads to the notion that the pupils' emotional vocabulary and self-awareness was improved throughout the intervention, meaning that they could identify their symptoms more effectively, which caused the illusion of detrimental effects to the therapy. Similar findings were noted in Salid et al.'s Norwegian mind power study, where the symptom increase was assumed to be attributed to destigmatizing and to the increased self-awareness. Weeks and colleagues referred to an increased post-session familiarity between student and practitioner, causing the client to become more comfortable revealing how she felt. This again forms the argument that there is a lack of knowledge surrounding mental health literacy and symptoms between both staff and students. A survey of Ofsted school inspection reports finds that schools are inadequately working towards the mental health promotion standards, and training for staff in mental health difficulties was an issue present in 3/4 of schools, meaning that a new approach to school interventions battling the adolescent mental health crisis in the UK must be adopted. The World Health Organization defines that socio-economic context must be respected and addressed to maintain mental health promotion. Mental health interventions are funded internally within schools' available resources funded by the Department of Education. However, school location is a vital contextual factor to the funding available to schools, since it has been found that higher SES of student population is significantly related to larger school expenditures per student. This finding pushes that societies are less meritocratic than it seems, and students from disadvantaged areas are not only more likely to experience mental health issues, but have less resources available as a protective factor to this. Interventions must target these at-risk disadvantaged areas to promote an equal society. The proposed approach includes the use of CBT within disadvantaged schools. The therapy should be targeted directly at students identified to be at risk by teachers. The aim of the therapy is to tackle socio-economic disadvantages within society, as well as mental health issues. It has been found useful when students are targeted for intervention, and this is additionally beneficial for students with limited resources, since it is in favour of a smaller scale strategy which is more manageable and sustainable. Findings by the Teachers Union, NASUWT, show that 98% of teachers reported the belief that they have come into contact with pupils who are experiencing mental health problems. This forms a suggestion that the teacher role should be to direct the most at-risk students and direct them to appropriate practices, since they are well equipped to do so. An issue that arises here is that teacher training is essential in formulating a well-grounded school-wide understanding of what defines mental illness symptoms. Adequate training of symptom detection will eliminate teachers feeling responsible and clarify their job description roles, whilst also overcoming some of the barriers to performing an effective working alliance between practitioners and teachers within schools. This collective approach is shown to be wholly effective in reducing adolescent mental health. CBT is founded alongside behaviourist theory, meaning that it focuses on drawing connections between the thoughts and feelings and their outcomes of behaviour. Behaviour which falls out of line with the school expectations is not only a risk factor to school exclusion, but is particularly common in low socioeconomic students. This articulates that CBT is best suited to students from a low SES background, since the method has been found to help overcome some behavioural issues holding individuals back from mental wellness and educational success. In practice, one study found that when CBT was targeted at individuals from low SES statuses, student retention rate was 97%, and both teachers and parents reported positive effect of the CBT intervention. These positive changes to disruptive behaviour had also improved further after a 3-month follow-up. Considering that the treatment retention rate of individuals from low SES backgrounds and disadvantaged areas is substantially low, this example retention rate of in-school CBT is impressive and groundbreaking. It has been noted that while school behaviour problems are typically reported in boys, emotional difficulties are more common amongst females. It is important to consider that the CBT method is inclusive of both sides of the spectrum, since it allocates a connection between emotions and behaviour. The advantages of targeting disadvantaged students also addresses socio-economic context, which is argued by the WHO to promote mental wellness, and this has some positive implications for wider society. Depression is known to be hierarchical. A study of baboons found that the stress hormone cortisol is heightened in times of being surrounded by people of a higher hierarchy. And a study on brain development found that lower cognitive development in children was correlated with low family income. Lower cognitive functioning increases the risk of mental health issues in children. These disadvantages directly make it harder for children to move up the meritocratic ladder in society to achieve success in life. Since school is designed to bridge the gap between home life and work life by creating a meritocratic ladder of success, then socio-economic disadvantages must be addressed to form equality. This means that intervention strategies should be directly targeting students from a low socio-economic background to create a more equal society that is truly meritocratic and fair. One limitation to this is that low socio-economic status has been found to be a buffer factor for intervention success. However, despite the lack of follow-ups from most studies, the studies that did follow up post-intervention reported that the improved psychological well-being remained significant for 12 months after therapy, meaning that when the intervention works, it works in a significant and lasting manner. Overall, interventions for mental health issues in schools are found to be most effective when targeted at individuals, since this improves client retention and interaction. Using teachers to highlight and target individuals with presenting symptoms of mental ill health has proved problematic, and teachers' training is required to form a well-grounded understanding of mental health symptoms and intervention principles to overcome these issues. Students from low socioeconomic backgrounds are at most risk of developing behavioural issues and mental health issues, so intervention strategies such as CBT should be appropriated in schools in disadvantaged areas to utilise the funding for specially trained CBT professionals. Overall, school-based interventions are in line with government policies to significantly reduce the rising mental health crisis in adolescents, and they have the potential to form collaboration between the health sector and education sector.